everyone for joining us today. We are excited to begin this webinar. Today, we will have our adult onset neuromuscular disease, red flags and testing for non-experts. Today, I have the pleasure to introduce Dr. Ericka Greene and Dr. Sheetal Shroff, and I will let you guys take it away.
Good afternoon. Hi, I'm Ericka Greene, and I have the pleasure of presenting this webinar with my colleague, Dr. Sheetal Shroff. We are neuromuscular specialists from Houston Methodist, and we run an MDA clinic. And it's our pleasure to present this seminar on neuromuscular diseases and the red flags. So I'll go right in and talk about our learning objectives, which, as you see on the slide, to recognize the symptoms for the most common adult onset neuromuscular diseases, including ALS, myotonic dystrophy, Emery-Dreifuss, facioscapulohumeral dystrophy, limb-girdle muscular dystrophies, and others. And so you'll see a lot of acronyms for those who are non-neurologists as well as neurologists, and we'll explain those. But many of the diseases that we'll talk about are the most common that we come across, and a lot of the content can be applied broadly when recognizing or when determining if a patient has a neuromuscular disorder. We'll also talk about the appropriate testing modalities that support a workup when you encounter a patient in whom you suspect has a neuromuscular disorder, and how to feel more confident in your referral of those patients to specialists such as myself and Dr. Shroff. So for the agenda, let's see if I could, thank you. We'll do some level setting. Why is this important? What are the signs and symptoms? What does neuromuscular disease look like? And what are the tools that we use to evaluate a case or screen for a case? And then we have a couple of case studies to sort of test your knowledge. You'll hear myself and Dr. Shroff sort of express what are the red flags we've recognized, and then we'll summarize and open up to a Q&A. So level setting, why is this important? Because neuromuscular diseases, although compared to hypertension, compared to cancer, are relatively rare, in neurology, they're very common. And often patients go undiagnosed long before they come to see myself as specialist. And by that time, they've seen their primary care, other subspecialties, and general neurologists, and it can take months to years before they're diagnosed. It's challenging because often their symptoms are not specific to one disease, and their symptoms are common: weakness, fatigue, it could be functional. And so the level setting is to sort of all come into agreement that this is important. So our goal is to help our non-expert clinicians and providers help us evaluate these patients by recognizing signs and symptoms, how to begin the workup to help streamline referral so that those patients can come to experts who have therapies and or clinical trials sooner than later when we can have a greater impact. So we're going to have some photos, pictures worth 1,000 words, and a couple of case studies to really apply the knowledge, envision how you would use these red flags. We have some resources at the end for you, and we encourage you to share with your colleagues. So there are many types of neuromuscular diseases, and we pretty much categorize them from diseases that affect muscle, nerves, motor neurons, nerve-muscle junction interaction. And so we can categorize it based on that anatomy. And under those anatomic locations, you'll see that we categorize it by disease type. So for muscle diseases, that includes muscular dystrophies, inherited muscular dystrophies. Again, we're confronted with these acronyms: the dystrophinopathies, Duchenne and Becker's, the congenital from birth, impacting development in utero and postnatal muscular dystrophies. Some of the more common limb-girdle muscular dystrophies or Emery-Dreifuss, those that affect the eyes, and then another very common adult onset myotonic and fascioscapular. When we talk about motor neuron disease, we're talking about the cells which are pure motor and navigate the motor function within the spinal cord and the brain. And so the most common that we're confronted with and we see is, of course, amyotrophic Lou Gehrig's disease, amyotrophic lateral sclerosis, spinal bulbar muscular atrophy or Kennedy's disease, or spinal muscular atrophy, SMA. And then you have the other host of categories from the ion channels, where it's not a muscle dystrophy or fibrosis, it's the functional activation, the excitation, contraction of the muscle is affected due to a channel mutation, or metabolic, such as mitochondrial diseases or glycogen storage diseases. You also have just other myopathies, which we'll talk about, that might be acquired, and neuromuscular diseases, the most common being myasthenia gravis, Lambert-Eaton, and there are inherited forms as well. And then lastly, the host of inherited neuropathies, the most commonly known as Charcot-Marie type category. So you can see when you're looking at just these broad categories, within each category, there are 20 to 100 different subtypes. And so it can be daunting. Next slide, please. And so recognizing the red flags, again, I've already talked about the benefits of early identification, because the earlier these patients are identified, the sooner they can be diagnosed, begin a treatment program. We now have interventional therapies which impact disease course. But it matters for the patient, because for any patient who doesn't understand what they have, why they have it, there's a significant amount of anxiety, frustration, and despair when you're suffering and functionally declining and you don't know the reason or the outcome or what the future holds. You know, knowledge is power. Even if we don't have therapies that change the natural history of the disease, just by giving a patient a diagnosis can give them a sense of empowerment where they can engage in therapies and rehab to improve their quality of life. They can make informed decisions. And again, I've already talked about treatments, which are now increasingly approved that impact disease course. And of course, the assumption is the earlier we start, the better. And then we can begin to make the appropriate accommodations for patients once we have that right diagnosis. And so, and lastly, you know, it requires a village. Most of these diseases require multidisciplinary care with multiple providers at all levels of care. And the earlier we can start that, the better for the patient. From there, I'll give it to Dr. Shroff.
Yeah, thank you, Dr. Greene. Next slide, please. Now we're going to move on to some of the clinical features, you know, like when should we suspect a neuromuscular disease in our patients, you know, when we encounter them. So abnormal muscle function is one of the defining feature of these neuromuscular diseases. Now, these neuromuscular conditions can be inherited, and some of them are because of de novo genetic mutation, meaning they're the first ones in the family to have this condition. Now, in clinical history, when we see these patients, you know, they can have like history of frequent falls, history of joint braces, or like multiple surgeries around the ankle, you know, like in childhood. They can have exertional myalgias where, you know, this can impair them with like strenuous activities or sports and things like that, history of cramping, and particularly it can affect the calf muscles. And also, you know, like the ones which are inherited, there is like an inheritance pattern, you know, whether it's autosomal dominant or recessive, and we're going to go over this, you know, in the next few slides. Early cataracts, you know, and history of heart disease or irregular heart rhythm or arrhythmias in the family or in the patient. So these are all some of the history which we kind of ask in these patients when we encounter them. Most of these patients, you know, they think, okay, I'm here to see a neurologist, and they don't, you know, disclose whether it's a cardiac symptom or a respiratory symptom or like anything else, you know, which is involved like an orthopedic issue. So they don't disclose. So sometimes it's important to dig in a little bit more in detail in the history when we encounter these patients. Now, muscle symptoms, it can be categorized either as fixed or episodic. So fixed means like gait. They can have like an impaired gait, and that's not going to alter or change. They just have an impaired gait. Joint contractures, which kind of tells us that this muscle weakness is long-standing. High arches, hammer toes, in patients with inherited neuropathies like Charcot-Marie-Tooth. So they have these high arches and hammer toes. Again, it tells us that this is long-standing, means they might have had this for years. Skeletal deformities, scoliosis. Again, this is because of weakness in the paraspinal muscles and the muscles supporting the spine. This can result in scoliosis. Now, proximal or distal muscle weakness, that is the pattern where the muscle weakness is important. And if there is atrophy, shrinking of these, muscles, the bulk of the muscles itself, respiratory difficulty, and then droopy eyes, so these are all some of the muscle symptoms, which can be fixed in these patients. Now, episodic symptoms means this can happen intermittently throughout their life. One is rhabdomyolysis. That's the breakdown of the muscles with minimal exertion or with exertion, where they end up having to be admitted to the hospital with elevated creatine kinase, requiring IV fluids. And this might have happened, like few times in their lifetime. But in between these episodes, patients can be completely normal. Fatigable weakness, like we see in myasthenia gravis, where, like with repetition, there is, they get weaker, the muscles get weaker. Myalgia, that is achiness in the muscles. Exercise intolerance in some of the metabolic myopathies like glycogen storage disease or mitochondrial disorders, where the muscle is not able to utilize the energy from glucose, glycogen, protein, fatty acid. So these patients, show exercise intolerance. And then double vision. So we see double vision in patients with myasthenia gravis. So like I mentioned, like these are episodic or intermittent, but then, these patients can be normal in between these episodes or episodic muscle symptoms. Now, in addition to this, there can be some other abnormal neurological exam, like droopy eyes and extraocular muscle weakness, where their eyes, like the extraocular muscle movement is limited or restricted, reduced deep tendon reflexes, or it could be absent reflexes as well. Weakness of respiratory muscles, which can cause symptoms like they need to catch a breath, to talk a full sentence, or they might have a weaker cough. And we're going to go over these, like clinical symptoms a little bit later in this presentation. And bulbar muscles, that's the muscles of speech and swallowing, can be involved, and then they can have impairment in speech, slurring speech, or choking when they swallow. And then atrophy of muscles, like as I said, a reduced bulk of the muscle itself. Next slide, please. Now, why is all this important? It is important because, observation, history, detailed history, and examination are the key things which can help in earlier diagnosis. So delayed diagnosis is due to lack of observation or lack of in-depth history, or not enough examination can lead to delayed diagnosis. And that's why, this is so important. And sometimes it might take a few encounters, like one might not be able to come to a diagnosis of a neuromuscular disease or a condition right away from the first diagnosis. It could be, just in the beginning of the condition or the disease, where they don't fit all the criterias and check all the boxes, like for the diagnosis. So it might take several encounters. Even for us, sometimes when we see patients, we're like, okay, we suspect this, but they don't fully fit this condition or fully fit the criteria. So we have to follow these patients along. And at times, it does take these several encounters to come to a diagnosis, to come to confirm that, they do have a neuromuscular disease or a condition. And also at times it's important to revisit the history and then get more details about the family history, and then repeat examination periodically to see how the pattern of weakness or how this initial presentation has changed or evolved over a period of time. And then lastly, to determine, okay, where is this problem coming from? Is it a nerve or is it a muscle, a motor neuron or neuromuscular junction? Like anatomically, like where is this, problem, or where is this condition arising from? Now, in this next slide, it kind of gives like a anatomical classification of these neuromuscular diseases. I know Dr. Greene went over this, briefly. Now you can see, starting more distally away from the nervous system, is the muscles. All the dystrophies, the metabolic or the mitochondrial myopathies, the ion channel disorders, these storage disorders, glycogen storage, fatty acid, and then inflammatory conditions like myositis, endocrine, and then as well as like statin myopathy. So all these, are different myopathies which can affect the muscle. Now, moving a little further proximally, like after the muscle, we have the neuromuscular junction. So this is where the nerve and the muscle kind of communicates with each other. So here, myasthenia gravis or some of the inherited forms like congenital myasthenic syndromes, they affect this neuromuscular junction area. Now, a little bit more proximal, then we have the nerves, So here, there are two categories of these motor neurons. We have the lower motor neuron and the upper motor neuron. Now, the upper motor neuron, as you can see, it starts from the brain, and the cell body, you can see that red dot, which is in the brain, and then it has a long axon which comes down to the spinal cord and it ends in the spinal cord. This is the upper motor neuron. And then we have the lower motor neuron where it actually originates in the spinal cord and then it travels outside the spinal cord in the form of motor nerves, and then it kind of supplies the innervates the muscles. Now, whenever these lower motor neurons are affected, then it can cause conditions like spinal muscular atrophy, polio, peripheral nerves, Guillain-Barré, Charcot-Marie-Tooth, all of these, are the lower motor neuron or lower motor nerve, diseases or conditions. Now, the upper motor neuron diseases is anything which affects, more in the brain and the spinal cord, like cerebral palsy, multiple sclerosis, transverse myelitis, stroke, traumatic brain injury, spinal cord injury. All these, can affect the upper motor neurons. Now, when we see a combination, that is the upper motor neuron and lower motor neuron, both of them are affected in the condition. So that's when, we see the condition called as ALS or amyotrophic lateral sclerosis, also called as Lou Gehrig's disease. So these are all like the variety of conditions, neuromuscular diseases classified based on the anatomical location where the nerves or the muscles or motor neurons are affected. Now, moving on to the next slide. So when we examine patients, it's important to look for pattern of weakness. When we say pattern, okay, is it on one side or is it on both sides, symmetrical versus asymmetrical? Now, it kind of helps us, narrow down or to come to the diagnosis. And where is it located? Is it only the proximal muscles like the shoulder and hip, or is it distal, like more in hands, feet, leg, forearm, or does it involve both proximal and distal muscles? And when we see when we suspect neuropathy, so in these patients, okay, is it only the motor nerves? Is there only weakness, or is there sensory deficit? There's numbness, they can't feel the sharp pain, they can't feel the vibration, they don't know where their joints are, the joint position or the proprioception is affected. So what is involved? Is it motor or sensory or both? And then how are the reflexes? Whether these the deep tendon reflexes, are they increased, reduced, absent? So what is how do the reflexes are in these patients. And also the bulk of the muscle. So is it shrunk, that's atrophied, or is it hypertrophied? That is, there is increased bulk, or pseudo-hypertrophy. So again, this is also increased bulk, but not necessarily only of the muscle tissue, but then, something else is also causing that hypertrophy kind of presentation. So all of these, is important to narrow down or to look for, to narrow down, to come to an diagnosis in these patients. Next slide, please. Now, like I mentioned in the previous slide, the distribution of weakness, yes, the picture, speaks a lot more than the words. Now you can see in this picture A, like, Duchenne and Becker's muscular dystrophy, like is one of the most common ones, which we hear. You can see, like it's more of this proximal upper arm, and then upper chest, and then in the legs, mainly the thighs, proximal legs are more affected. And then you can see Emery-Dreifuss. It's also called as humeroperoneal muscular dystrophy, like, as the name kind of goes by, humerus, which is along the upper arm and upper chest, and then the peroneal, that's the front of the legs. So the tibialis anterior, those are the muscles, the front of the leg, which can get affected. And these patients can have what we call as foot drop or dorsiflexion weakness. And that's why, presentation is important. As you can see, like sometimes when we see this different pattern of muscle weakness, then we can think of, okay, this is most likely, it could be Duchenne, or it could be limb girdle or facioscapulohumeral. Now you see limb girdle again, as the name suggests, it's the girdles, right? The shoulder girdle, the muscles around the shoulder, or pelvic girdle, the muscles around the pelvis. So those are the muscles which are affected. Facioscapulohumeral. So again, fascio, that's the face, is affected, and then the scapular, that's around the shoulder girdle, and then and the humerus, the upper arm, and then in some advanced cases, we do see involvement of tibialis anterior, and these patients can have foot drop. And then we have distal pattern, where only like, forearm, hand, and then leg and feet are affected. Then we have the oculopharyngeal, where you can see that's the eyes, around the eye muscles, and then the pharynx, that's the swallowing muscles, and then as well as the shoulder and the hip girdle. So you can see the variety of presentation, and sometimes, it helps us narrow it down to come to a diagnosis. Next slide, please. Now, once we have, once we see, in the history or in the examination, and then we suspect a neuromuscular disease in our patient, so there are a variety of tests which are available, which can aid in earlier diagnosis. Blood tests such as creatine kinase, aldolase, screening for endocrine nutritional abnormalities or deficiencies, inflammatory markers, and autoantibodies, and then EMG nerve conduction studies, which kind of help us narrow it down. Is it a neuropathic or a nerve-related condition, or a muscle-related condition, or is it a neuromuscular junction-related condition, or a motor neuron disease? Then we have MRI, where we can use to image the affected muscle to see if there is inflammation, atrophy, and then muscle biopsy. So now that like we have more and more genetic testing which is available, and some of which are commercially sponsored ones which are available free of cost. It is much more less invasive way of testing, as well as getting a confirmation. So with the expansion of genetic testing, the muscle biopsy is reducing slowly, but still, muscle biopsy is one of the go-to tests whenever we see muscle and nerve conditions as well. And ultrasound, where muscles can, in the affected areas, the ultrasound can be used to assess the muscle as well as the nerve, and it can help with targeted muscle biopsy as well. Now, once we have all these, tools to assess neuromuscular diseases, and when we encounter these patients, it's really helpful for these patients to get a earlier diagnosis with using all these tools. I'm going to hand it over to Dr. Greene.
All right, next slide. Thank you, Dr. Shroff. So let's take a look at some pictures and sort of make some comments. So what I'm showing you here is some things you might see as your patient walks into the office, into the clinic. You know, just as Dr. Shroff said earlier, observation is the key. A lot of times we will stumble over diagnoses because we observe something that's atypical, and it may be the first visit or it may be the fifth visit. And so the first set of photographs is of a patient who has an autosomal recessive type of limb girdle muscular dystrophy, and that should be 2D. It's an alpha-sarcoglycanopathy, and once you take this person's clothes off, you see the atrophy around the scapular region of the shoulder girdle, especially under the deltoid and lateral and somewhat medial to the scapula. If you take a look at his habitus standing in front of you, you see how his knees are hyper extended and locked. You can't really appreciate it, but you can see from there that his chest is pitched forward. Often patients will pitch forward so that their center of gravity is intact. And compared to the bulk of his upper body, his legs are notably smaller. Now, a lot of these limb girdles have large calves, but over time they can lose their large calves. We call that pseudo-hypertrophy of the calf. But even relative to his quadriceps, his thighs, his calves are relatively somewhat larger. Again, to the right is the classic Gower's sign that was first described in young boys who inherited Duchenne, the dystrophin mutation that causes Duchenne muscular dystrophy, and a less severe mutation, Becker muscular dystrophy. But it's not specific just to these types of dystrophies. We see this type of modified and compensated movement to get up from a sitting or from the floor position in other dystrophies, including limb girdles. And so what you'll see is if you look at the picture starting from A, that the child is sitting down, and instead of just rising up with his hands on the ground and pushing himself up, they have to hyperextend and spread their body out, spread their legs apart because of the significant proximal muscle weakness in their pelvic girdle. And just as you see in the lower illustrations, the person will climb up on their body using their arms on their thighs, then on their hips to stand. In an adult patient, you won't necessarily see this from the ground up, but you'll see it from a sitting position where they will place their hands on the bed or a table, just as the child is placing his hands on the floor, spread their legs, and then rise up. Paying attention to the stance under letter H is the lateral view of what you see the gentleman doing face forward in the pictograph. You see that the abdomen is protuberant. There's curvature, what we call lordosis of the lower spine. The upper body is pitched forward. The knees are hyperextended and locked. It's because the center of gravity is off, and this is the compensatory mechanism which many of these patients display to maintain themselves upright, legs far apart. Again, not specific for any particular one, but first classically described in boys with Duchenne muscular dystrophy. Next slide. And I hope this video works. This is a patient with another autosomal recessive limb girdle muscular dystrophy, a calpain mutation. See if we can start this video. And this would be someone who might walk into your office. And what you'll see is because of the pelvic girdle weakness, the patient will pitch forward their leg instead of raising it at the hip. They'll push their leg forward. You see they're not picking up their feet. It's wide-based, and their arms are sort of, you don't see a lot of swinging. Again, their abdomen is pitched forward. Their buttocks are pitched forward. And their abdomen is protuberant, in order to maintain their center of balance as they walk. Now, for those who see patients coming in, you may not see it this advanced, and you may see a more subtle form. But again, the key is to observe, and you might have to do it over several visits. All right, again, so let's say you have a patient who comes in with distal weakness like the last patient, but you shake their hand. Go ahead and click the slide there. And when you shake their hand, they have delayed opening, like this gentleman. This is called myotonia. It is impaired, maybe play it again if you don't mind. It is delayed relaxation of muscle contraction. It can be elicited by hitting the muscle belly of the thumb, the thenar eminence. It can be induced by activating contraction, and often it'll be noticed when you shake that patient's hand. Or the history might be when I grab the doorknob, when I shake hands, it takes a while to open. If I haven't moved for a while and I get up, my legs are stuck. It takes a while for them to loosen. This is something we see in myotonic disorders. The most common we see is called myotonic dystrophy, and it stands out because it not only has muscle weakness distally, unlike limb-girdle muscular dystrophy, the most common types, it also has this electrical impaired relaxation called myotonia. To the right is a patient with ALS or amyotrophic lateral sclerosis. And as Dr. Shroff mentioned, it's a combination of both upper motor neuron and lower motor neuron. The upper motor neuron would cause weakness, but they would be hyperreflexic. When you tap their knee, it would jump very quickly. It would be a 3 or a 4. They might have clonus. But because they also have lower motor neuron involvement, please click the video again, you'll see evidence of lack of innervation. So you'll see the atrophy. What this is showing is the fasciculations of the muscle in the gastrocnemius and the related posterior compartment of the leg. And you see the atrophy of the thigh and the calf. These are signs, atrophy, fasciculations in the context of weakness, in a combination with low reflexes and increased reflexes, very suspicious for ALS. Next slide. And Dr. Shroff, I'll let you take it.
Sure. Thank you, Dr. Greene. Now, moving on to a different area of the body, the face. As we discussed, in some of the muscular dystrophy like facioscapulohumeral dystrophy, there is facial weakness. Like you can see in the first picture where the patient is trying to smile and then, it's not symmetrical. And then there is both sides, the face is weak. And then in the middle, the second picture, you can see the droopiness of both the angle of the mouth, like the mouth droops. So it basically tells us that this is there is facial weakness. The muscles of the face are weak, and typically these symptoms or these features are there for a long period of time. Whenever there's a facial droop, yes, like one suspects, okay, is this stroke? But if you ask these patients, these are long-standing. It's been there for many years. So that's kind of, indicative or suggestive. And these patients also, because their face is weak, facial muscles are weak, they can have drooling at the corner of the mouth. They might not be able to puff their cheeks well. Sucking from the straw might be difficult, and these patients might not be able to whistle, so these are some of the things, like which sometimes patients might tell, or when we ask them, they say, yes, I have never been able to whistle all my life. So that's some of the things which we get from the history. Now, in this second picture, this is a picture of myotonic dystrophy type 1 with a mom and newborn, where you can see, in the mom, there is a slight droopiness in her eyes, and then the temporal area, there is hollowing, like the kind of like a little depression in the temporal region on both sides. And it is, a little bit more prominent in the baby. And these patients also have like high arches, which I think Dr. Greene is going to go over, later on when you examine their mouth. And one thing in myotonic dystrophy is there is something called as anticipation. So this anticipation is a phenomena where the myotonic dystrophy, the disease, the symptoms are much more severe, and they manifest at an earlier age in each successive generation. So if the mom had symptoms, say in her 50s, then the child, say the daughter, could have symptoms, like in their 20s. And then, when that daughter has her child, the grandbaby, then, maybe born with the symptoms, so that's like that trend or that pattern is called as anticipation. And it's really important, piece of history to ask these patients when we see them. Next slide, please. So here, this is a patient with fascioscapulohumeral dystrophy again, and you can see here on the first picture where there is a prominent axillary fold, and then the muscles of around the shoulder girdle, the arm, like is slightly atrophied. The clavicles are kind of straight. I think it's hard to see in here. We'll see in the next few pictures. Straight clavicles. And then when we examine at the back, when we ask these patients to lift their arms up forward and kind of push on the wall, we see what is known as winging of scapula. So scapula, that's the which kind of part of the shoulder girdle is stabilized by multiple muscles. And when these muscles get weak, the scapula is not stabilized, and then it protrudes. And that's called as the winging of scapula. So it's important to examine the back of the patient as well. And then in these patients, there's something called as beaver sign, where, as you can see here below, where this patient, she's laying down flat on the left, and you can see the umbilicus, close to the bar, the bar. And then when we ask to lift the head off the bed, the umbilicus then moves up, and this basically, suggests weakness of the abdominal muscles, which results in, like a displacement of the umbilicus when they activate by lifting the head up. And then we have on the right-hand side, we see high arches and hammer toes. As you can see, like the hand is and hand muscle atrophy as well, like how prominent some of those hands tendons have become, where you can actually see the hollowness in between the tendons, and there's definitely loss of like the muscle bulk itself, so there's atrophy of the hand muscles. And in the bottom right, like we see the high arch foot, which basically, again, weakness of these small muscles in the foot, which kind of results in the high arch and then hammer toes. And this we see in Charcot-Marie-Tooth and some of the inherited neuropathies. Next slide, please. Now here, this is again, a patient with facioscapulohumeral dystrophy. Now, you can see on figure A, when patient is asked to lift their arm to the side, abduct their arm, they can only go to a certain degree or certain level. And then in figure B, you can see like by manually positioning the scapula, their range of motion increases. So this basically, kind of tells us, would this patient benefit from any surgical intervention which can help fix the scapula so that their range of motion can be improved. Next slide, please. So here, this is these are some group of muscular dystrophy, more so in LGMD, where we see more contractures because of long-standing weakness. So the first top picture you can see in the hand where there is a contraction of the finger. This is mainly because of long-standing muscle weakness results in contracture of that joint. And again, in the top right picture, you can see the patient is basically, like not able to lift their arm up or fold their elbows as much. So there is contracture in the elbow, shoulders as well. Now we also see, like rigid spine syndrome, where basically in limb girdle muscular dystrophy, where the spine is so rigid and they're not able to bend, move, twist, like as easily as others would. So this is more of like very stiff spine and a rigid spine because of paraspinal muscle weakness as well. Next slide, please. I'm going to hand it over to Dr. Greene now.
Sure. So just like those contractures and the atrophy of the hands and feet that Dr. Shroff, the face, those to us are frank signs. When we see them, we pay attention. But to those who aren't used to seeing them, you can overlook them. You can think that it's just the normal variability in the face. But as you can see in the context of this presentation, these aren't normal variations. And so I encourage you to just to sort of be an observer of your patient. Some of the other soft signs that I've noticed was already mentioned is scoliosis. Scoliosis is not specific to one disease. We see it in many long-standing, particularly inherited congenital neuromuscular diseases. As Dr. Shroff mentioned, developmentally, even before they show weakness, the ability of their musculoskeletal system to develop as a person grows from childhood to adulthood is impaired. So we see the signs that there was some inherent intrinsic problem with the development of the musculoskeletal system. And one soft sign is scoliosis. We call it a soft sign because by no means is scoliosis specific to neuromuscular disease. It's a condition on its own. But in the context of someone coming to you with fatigue, weakness, falls, and imbalance, it's something that we pay attention to and we measure. Again, we've already talked about the high arches. Again, you see the normal illustration where the arch is of a normal curvature or angle versus someone who has a pre-existing long-standing acquired or inherited disease that causes muscle atrophy or weakness. And in someone who has always had high arches and hammer toes and they have some degree of weakness, we're suspicious of an inherited condition. And we may ask how long they've had that. Was it as long as they can remember? Have they ever had surgeries to correct a rolling ankle or hammer toes? And is there a family history of the same? And then another soft sign that I particularly pay attention to, again, a soft sign of abnormal musculoskeletal development because of some intrinsic problem. And that is a high arched palate. Again, none of these are specific to neuromuscular disease, but in the context of someone coming to you with some symptomatology, we pay attention to it. And I would say the vast majority of patients who have an inherited neuromuscular disease have a narrow, higher arched palate, as you can see on the right, with maxillary constriction. We typically have a nice cross bite here in the front, and you lose that with the narrowing. And again, this is a soft sign that developmentally the musculoskeletal system did not develop fully. Okay, so we have some cases, and we welcome your questions at the end. So I'm going to present that and ask Dr. Shroff to sort of give her thoughts about it. So this is a 61-year-old man who was first encountered in the hospital with acute inflammatory demyelinating polyneuropathy, or Guillain-Barré. And he had the variation called Miller-Fisher, which is associated with facial weakness. He had impaired smile, he couldn't drink well, he was drooling, and that was in 2010. He recovered from that and continued to follow up for Guillain-Barré recovery. He also had a history of diabetes, obstructive sleep apnea on CPAP, reflux, hyperlipidemia, and thyroidism. And over time, he stabilized, but he continued to have some facial weakness and complained of extreme tiredness and weakness, even with exertion. And he was seen by cardiology and other subspecialties. And then after several years, he started to complain with sharpness of his right shin bone, that his shin bone looked like a sword. In other words, his leg was atrophying, and he could see the outline of his tibia, and the leg appeared smaller, and it was just the right side. He was no longer able to walk as fast, and often his right foot would drop or slap on the ground after several steps, and he began using his own ankle brace. In terms of review of systems, he complained of more muscle aches and just extreme exhaustion at the end of the day with walking and getting in and out of work, more weakness of his mouth when talking or eating. He had impaired closure. His wife noticed that for a long time, but it was getting worse. When he slept, his eyes were a little bit open and his mouth would not close completely, so he had more of a dry mouth. He denied some of these other review of systems that you see. He had no vision changes, no lid drooping, no swallowing issues, no chewing issues at the time, and no other constitutional symptoms. Because of diabetes, he did lose weight on his own, but his wife noted that above and beyond that, his core was weaker and his right eye didn't close completely. You can see the family history there, the common diseases, heart disease with death from his mother from a blood clot, and father with heart disease and Parkinson's, and he lived a fairly healthy life. So I'm going to open it up to Dr. Shroff. And Dr. Shroff, what are your thoughts here in someone who's been followed after recovery with some weakness?
So yes. So I do think, to me, the history of Guillain-Barré is important. It did, like result in facial weakness. So I'm gonna keep that in mind. But he had a complete recovery. So that means he had gotten back to his baseline, and now he is showing weakness and tiredness with exertion. So there might be something else going on. So that's kind of what I'm thinking. And, that sharpness of the right shin bone. So basically he's telling, like his shin has gotten more prominent, means the tissue around it, or like the muscle, might have shrunk, and that's probably why he's noticing the prominent shin bone. And he says his leg is smaller as well, so that kind of tells me there is some amount of muscle atrophy going on in his leg. And then his right foot slaps, and he started to use a brace. So I'm thinking, okay, so there is muscle atrophy, maybe foot drop, and that's why he's using a brace to walk. So that's kind of what I'm thinking. And then muscle ache. So and with more use, so he's tiring out. And also there is some weakness in his mouth when talking and eating. So there might be weakness of his facial muscles there as well. And like this kind of caught my attention when it says like his wife noticed that his right eye does not close completely. So there might be some like the muscles around the eye which is weak, and he's not closing, and that's probably why he's having the dry eyes. So kind of in family history is just it doesn't seem to me anything like major in the family history. So basically, to summarize, I'm hearing there is some loss of muscle in the leg, with maybe right foot drop, and that's why, or foot drop, and that's why he's using the foot brace, along with some face weakness as well, facial weakness, along with the weakness around the eyes. So that's kind of, what I think. Yeah.
And I think it's hard to say, okay, is this an inherited or acquired? Is this recurrent Guillain-Barré? Probably not, because it's going on over time. But do you have enough information to say, is this muscle, is this nerve, is this motor neuron, or what would you leave it open?
think I'm gonna narrow it down to muscle because he's not saying, you know, like any numbness or, you know, like anything. There's no sensory symptoms which I'm hearing. So that's why, you know, I think I'm gonna narrow it down, or at least I'm gonna put the muscle as, you know, high in my differential. Yeah.
Wonderful. So we're going to put a pin in this case, and we're going to go to the next case, and Dr. Shroff, and then we'll come back to these cases and see what we found.
Yeah. Now, yeah, next slide, please. So I'm gonna present the second case, and we'll get, you know, Dr. Greene to kind of give her thoughts about this case. This is a 41-year-old gentleman who had 20-year history of weakness, pain, and shortness of breath on exertion, with change in ability to run in mid-20s. So he pretty much stopped working as a construction worker 2 years earlier, and he's been on disability. He's had several ER visits because of joint pain, back pain, leg edema, shortness of breath, and somewhere, you know, it's been mentioned that, you know, like this is seen as drug-seeking behavior as well. Now, in the last visit, he was given IV morphine because of the pain, and he ended up with a respiratory failure, intubated, unable to extubate, so he got trached and then PEG placed as well for nutritional support. Past history, he had hypertension and then history of rhabdomyolysis after a lightning strike. So that's kind of the past history. Next slide, please. And family history, his father had brain cancer and passed away. Mother and sister had migraines. There's no other muscle, lung, or cardiac history, or no consanguinity as well. Review of system basically tells us that there is lower back stiffness, which is chronic. There is no bulbar symptoms, no chest pain, palpitations. He always had a large calves, even as a child. There was no developmental delay, no goer sign or toe walking or anything of that sort. Had recurrent diarrhea and some migraines in childhood. There is history of alcoholism, drug abused. He's divorced with 2 children. And this is some of the workup, you know, which has been done during prior admission. CK of 458, aldolase 10.8, slightly elevated liver enzymes, but all the other myasthenia panel chemistry, cell count, all that is normal. And then he did have like a high CO2, PCO2, 70, and then, you know, after intubation got improved, and then echo is fine, CT, you know, looks fine as well, with just a minimally enlarged heart. Dr. Greene, what do you think, you know, about this case?
Well, even going back to the slide before, I think what stands out is the 20-year history, right? This is a 41-year-old man who was a construction worker and then had to stop working because he had a 20-year history of pain and shortness of breath. That's not normal. So the 20 years suggests to me that this is, if it's acquired, it's not severe enough to have led to a diagnosis. So I would already be concerned about some inherited process. Because if it's endocrine or inflammatory, or even ALS, he should have presented already, not 20 years. I think that's one thing. And the fact that in the 20 years, he noticed that he wasn't running the same way. So those are the historical things that sort of is a red flag to me, is how long have you not been normal compared to your relative peers at the same age. Now, the ER visits, because of pain and shortness of breath, drug seeking, he does have a prior history, so I can understand how the healthcare system can put him in that category, but it really speaks to what you and I were saying earlier, is you have to have an index of suspicion, because if this is something, a neuromuscular disorder, it's delaying his follow-up. And in fact, he's given morphine and he goes into respiratory failure. That's probably the biggest red flag, because if he is drug seeking and he has a prior history of drug abuse, then he should have built tolerance. But yet 1 dose caused him to be ventilated and trached. And so I'm already concerned about pre-existing lung disease, pre-existing muscle strength to ventilate. And so, and then the rhabdomyolysis, of course, we all could have rhabdo after a lightning strike, but in the context of everything else, the clinical course, the shortness of breath, the respiratory failure with one dose of morphine, I am definitely concerned of a muscle issue that has been going on longer than this past year for this case. And the laboratory studies and the review of systems for large calves would point and support that as well, that this is a muscle problem and probably an inherited one.
Yeah. So you pointed out all the red flag signs, like great, yes, that's a great kind of narrative and a concise, statement what you did, about all the red flag signs. Let's move on to the next slide, please.
Okay, I think that's me. So we're going to talk about, so now you have your patients. Let's take these two patients. And what do you do? Well, we provided family history, but family history is key because you want to ask about, are there other family members who have experienced what you have experienced or look like what you look like, or have your feet, as we talked about, or had braces. And so you want to ask about their parents, siblings, to get an idea if this is something in the family and to get some idea of the type of inheritance. And so in the left, you see the boxes, it shows autosomal dominant inheritance. This is where a gene mutation is dominant. And so one parent can have that gene mutation. And if it's dominant, and it can penetrate and cause disease. And so each child from that couple has a 50-50 chance of acquiring that parent's mutation. And so that's autosomal dominant. So there are autosomal dominant limb-girdle muscular dystrophies. There are autosomal dominant familial ALS syndromes, as well as Charcot-Marie Tooth diseases, compared to autosomal recessive disorders, where this is a mutation that by itself on one allele is not enough to cause disease. It requires 2 copies. So both parents are carriers of this recessive gene. And if they have children, then it requires both parents to pass that gene for 25% of their children to inherit both. And so that would mean that 25% of all their children have a chance of having both alleles affected and thus have the disease, whereas 50% have a chance out of all their children of just being carriers, and of course 25% not as carriers. So we see this type of inheritance. So this could be the patient who has no family history. And this could be the sole person in their family, and it would seem to be sporadic, but it could be autosomal recessive because there are carriers in the family. And then you have somatic mosaicism, where it's about how the genes recombinate after conception, and how that mixture and how genes recombinate and they become activated that way. And so that's not as common, but again, that person can look like a sporadic case and can present. FSHD has some degree of somatic mosaicism. It is autosomal dominant, but it also has all of these other requirements that have to occur genetically besides just a gene mutation. So it can present sporadically as well in a family. The other thing about the history is the patient's childhood history, or the history of their parents or their siblings. Like the case before, he was in his early 20s when he noted a change. So you want to ask, how long have you been dealing with this? And a lot of the questions we ask is, when you played in the playground, when you went to PE, did you play sports? Did you have more trouble recovering? Did you fall a lot? Could you keep up with the kids your age? Were you clumsy? Dr. Shroff mentioned toe walking in one of the other cases. Were you a toe walker? things like that. Did you use devices or braces? Did you have corrective surgeries? We don't see as many corrective surgeries, but in the past, we've met adults who had their ankles fixed, because that's what you did for kids with foot drop many years ago. So that's a sign as well. Next slide. Next slide. Thank you. And so I think the mistake is that many of these diseases people think it only affects the nervous system. It only affects the muscle, the skeletal muscle. It only affects the brain or the spinal cord, the nerve. But many of these inherited disorders, these genes affect other organ systems. And so when you're thinking about some of the dystrophies, because skeletal muscle is affected, also heart muscle is often affected and can be a cause of shorter survival and increased morbidity. So if you're suspecting a muscle disorder of any type, screening for the heart is important. It's an automatic, because many of these muscular dystrophies and myopathies can also affect the muscle of the heart and cause cardiomyopathies. And for myotonic dystrophy, even arrhythmias, fatal arrhythmias. Again, skeletal muscle, ventilation and breathing is mediated by the diaphragm and the intercostal muscles. So just as skeletal muscle is affected in the pelvic and shoulder girdle or in the calves and arms of these patients, it affects their breathing. It affects their ability to expel and clear carbon dioxide. And then we already talked about early contractures, fibrosis of the joint, which seems to be more dominant than the weakness. Muscle rippling, fasciculation, scapular ringing. We've talked about all this. And some of patients may have other things such as liver disease, skin disease. You might have early cataracts, such as in myotonic dystrophy. And some dystrophies have intellectual disabilities and developmental delays, such as in the dystrophinopathies, Duchenne specifically. And I think, Dr. Shroff?
Yeah. Next slide, please. Now, when we know these neuromuscular diseases can have this wide variety of involvement of other multiple systems, and when we suspect neuromuscular disease in a patient, what conversation, what are the things to ask these patients which can help us or aid in the diagnosis. So when we see, muscle weakness, or how to ask these patients about weakness in the extremities. So ability to lift objects overhead, like, getting the utensils out or heavy pots out of the cupboards, which are higher above their head, difficulty lifting the grocery bag from the floor, or just, like styling their hair, washing their hair, where we have to keep our arms, like quite some time, like up above our head, and using those muscles is that difficult. And then hand grip, like Dr. Greene showed the video of the myotonia, like, is there stiffness where it just gets stuck, I'm just not able to release my hand. And some patients even say, like, I avoid shaking hands because, like my hand gets so tight, and I'm embarrassed because it looks like I'm holding their hand for a longer period of time. So they give that as that history as well. Falls, and then getting up from the floor, like Dr. Greene showed a picture of the goer sign, where they have to climb themselves, or getting up from the chair where they have to really push themselves out or swing themselves forward to get up from the chair. Climbing stairs. So difficulty climbing stairs, going up, and some patients might say, getting down the stairs is difficult. That's more with like the hamstring or the back of the thigh weakness. So these are all some questions we can ask to tease out, or like get a little bit more history about the muscle weakness in extremities. Now, the weakness in face and the bulbar muscles of the speech and swallowing. So here, more so, sometimes it's the patient, sometimes it's the family members who notice, that they're not able to close their eyes tightly. And when they sleep, their eyes are a little bit open, or they see the white of the eye, or when they wake up, their eyes are dry and kind of irritated just because they're not able to close their eyes, unable to whistle. And then, patients who have eyelid droop, they have history of multiple eye lift surgeries where, they would have had eye lift surgery, and after 2 years, their droop comes back, and then they go back again, and then they have eye lift surgery. So that's again a clue towards the weakness of the muscles around the eye. Double vision, speech difficulty, like where where it's slurred, or when they're speaking on the phone, they've been asked to repeat the words or repeat the sentences numerous times. So these are all like some of the features of muscle weakness of the face and of the bulbar muscles. Respiratory weakness. Now, this typically we see the involvement of breathing when patients with, neuromuscular disease, they are severely weak in their legs, or they lose the ability to walk. One might say, like, my cough has changed, or my sneeze has changed. I can't cough as forcefully. I can't clear my throat out, or my sneeze, is not as forceful. Like initially I used to, have a forceful sneeze, and now it's like a very weak sneeze. It's not as forceful. And then they do notice that, laying flat on the bed, is difficult. Mainly they're not able to breathe as easily laying flat on the bed because of the weakness of the diaphragm. So these are some things, like patients might not say, but we might have to ask them to get that answer from them. Again, like I mentioned, like releasing the hand grip when shaking hands, and muscle stiffness in the cold weather are kind of signs of myotonia, which we can get in the history. Next slide, please. Now, once we ask them, when we examine these patients, what should we look for? For muscle weakness, we look for the bulk of the muscle. That is the muscle normal bulk, or has it shrunk? Is it atrophied? And then in the back of the patients, we look for scapular winging, which is basically because of the weakness of the muscles around the scapula. It's just not stabilized, and it kind of moves and protrudes out when patients like lift their arms up. Just muscle weakness when they're not able to resist, like when we examine the strength, muscle strength. And also the get up and go test, where patients, we just say, like, they require to push themselves up or swing themselves out of the chair to get up and then walk. Hammer toes, high arches, and then the gait, like in the video we watched, how it's waddling gait with the abdomen protruded, and with excessive lordosis. So the gait, watching how they walk. And when these patients have like foot drop, as we see in Charcot-Marie-Tooth, they have like a high steppage gait. They have to lift their entire leg up to clear off their toes off the ground, and then, take a step forward. So we see these different manifestations because of the muscle weakness. Now, in the facial and the bulbar muscle weakness, one can see droopy eyes, extraocular movements. The eye movements are not complete. They're restricted. They don't, their eyes don't move all the way to the corners. And then there is facial weakness. They're not able to puff their cheeks. They're not able to close their mouth tightly, and you can open them easily. There could be like a nasal tone to their speech. The speech can be slurred. So these are all some of the things, which we can see. Similarly, like Dr. Greene showed, the fasciculations in the calves, one can see fasciculations in the tongue as well, or fibrillations in the tongue as well in patients with ALS or Lou Gehrig's disease. So these are all some of the things to look for. Respiratory muscle weakness can manifest. Patients might not say, I'm short of breath. But when they come in, when we see them, they're using their accessory muscles, they're using their neck muscles and shoulder muscles, like to take a deep breath. And then they're not able to complete a full sentence without taking another breath. Like, for example, if I'm gonna talk in a couple words and then keep taking a breath, so they're taking multiple breaths, before completion of a full sentence. So that kind of it's an indication of respiratory muscle weakness. In myotonia, when we ask them to, grip the hand and, delayed relaxation of those muscles, frontal balding, scoliosis, head drop, some patients with myasthenia, ALS, they can have like a neck muscle weakness, and then they can have like a head drop, and then they can have fasciculations with patients with like Lou Gehrig's disease. We can see fasciculations in the muscles. So these are all the different things or clues, which we want to look for when we examine patients with neuromuscular diseases. Next slide, please.
Okay, so the diagnostic approach, there was a traditional approach under which I was trained and Dr. Shroff was trained. But as she mentioned earlier, because of the expansion, the availability of genetic testing, which has become much more economical and covers a wide range of different disorders, you can see between the new approach versus the old approach that there's a prioritization to genetic testing earlier in the diagnostic journey for patients. I think what's the same is the observation, the history, and the exam. It's really that can't go away. Nothing else really is as important as your clinical assessment of the patient, observing, taking their clothes off, watching them walk, getting a very in-depth family and clinical history, developmental history, seeing if there's an inheritance pattern. That's where it begins, because thereafter, it really directs your care and your approach. So traditionally, we would go straight to EMG, and to be honest with you, we still do. It's almost an automatic order along with laboratory testing. But in the past, we'd wait to get the EMG to confirm, is this muscle, nerve, both, motor neuron? And then almost every patient would get a tissue biopsy, whether it was muscle biopsy for myopathy or myopathy related disease, or a nerve biopsy for neuropathy. And then we look at the histopathology, and then we would decide based on the pattern seen, the pathology seen, did it give us a hint as to, was this a dystrophy? Was it inflammatory? Was it nutritional? Was it motor neuron? Was it demyelinating neuropathy or what have you? And then we would do the genetic testing. But often that would still leave us with a lack of a diagnosis, because more often than not, the pathology wasn't specific enough, or because of sampling, we weren't able to get a good sample to really look at the pathology, or there could be systematic issues with processing and interpretation. And so now, because we have whole genomic sequencing, exomic sequencing, we have next generation sequencing where we can look at 10 to 20 different genes to cover a panel of different disorders across many commercial agencies. We've been able to spread a much wider net. And what we found is that by going straight to genetic testing, we've discovered that one gene can present with multiple phenotypes, and one phenotype can have multiple genes. And I think with the availability of genetic testing and what it showed us, that's why it seems to be an earlier step in today's diagnostic approach versus prior to having all of these resources. To be honest with you, we still do EMG, nerve conduction, probably parallel or prior to genetic testing. But as Dr. Shroff mentioned earlier in our talk, muscle biopsies are becoming fewer and fewer. They're rare. We just don't need to do them as much. They don't add as much as the genetic testing in lieu of the patient presentation. And typically it's done when genetic testing testing has not yielded a diagnosis. And you really just have to see something that would give you a clue as to what's going on. Dr. Shroff?
Yeah. Next slide, please. Now, going back to case one, the workup showed like multiple autoantibodies for the neuropathy, myasthenia gravis, nutritional, metabolic, cancer screen. All those were normal. A lumbar puncture was done since, patient did have history of Guillain-Barré, so that was normal. EMG nerve conduction study showed some mild neuropathy changes, and since, he does have history of diabetes, so it could be that he might have diabetic neuropathy. MRI of the lumbar spine was also unremarkable, had some arthritic degenerative changes, but nothing suggestive or nothing which would suggest would be contributing to his weakness. Pulmonary function studies were normal. Now, next, we got an in-depth history and examination of this patient. So before this patient had or presented with Guillain-Barré, the patient had a long-standing history of impaired eye closure, and then inability to whistle, and never was strong in his arms. So these were some of the history, which we got upon digging some more. Next slide, please. And then, so we examined him, we took off his shirt, and then this is what we see. As you can see on the image on the right, on the left, basically, there is some wasting or atrophy of the muscles around the shoulder area. And the image on the right, you can see there is he's not able to lift his arms any higher up, and there is, and you can see how the clavicle or the front of the chest, the pectoralis area, kind of sinks in when they lift their arm, when he lifts his arm up, basically telling us there is weakness of those muscles around the shoulder girdle and the anterior chest area. Next slide, please. And here, so this the picture on the left basically tells us you can see the arm and basically forearm are about the same size. That basically tells us that there is atrophy of the muscles around the shoulder girdle and the arm. And the bottom picture, I think it's not and clearly seen, but you can see there is a little, like a protrusion of the scapula, when the patient puts the arm in front of him like a stop sign, that's when we see this protrusion of the scapula, and this is called as the scapular winging. And this was seen upon examination of the back muscles or the back of the patient. Next slide, please. So the genetic testing results of this patient ended up coming positive for facioscapulohumeral dystrophy with the contraction of this D4Z4 repeats. So basically, this patient has FSHD, that's the facioscapulohumeral dystrophy. Next slide, please. Now, facioscapulohumeral dystrophy, it's an inherited genetic muscle condition. As the name suggests, involves the muscles of the face, the shoulder blades, and the upper arm. And it is the third most common muscular dystrophy, and the onset can vary. There is no particular age of onset, and it can vary. In US, 1 in 15 to 20,000 individuals are affected. It is more common in men, but women can also be affected, but they have a later age of presentation and a lesser severe presentation as well. 95% are Caucasians, 4% Asian, and less than 1% Native American are found to have this facioscapulohumeral dystrophy. Next slide, please. Now, this is a mom and a daughter with FSHD or facioscapulohumeral dystrophy. And some of the presenting symptoms of this muscular dystrophy is inability to move the arms above the shoulder height, which is very important. There can be asymmetric muscle involvement. One side is slightly more affected than the other. And there are subtle signs like, inability to close eyes completely during sleep. And this usually patients don't say this because they don't know, what they're doing when they're asleep. It's usually the family members who give that history of, that they don't close their eyes. The patient don't close their eyes completely when they sleep. Scapular winging, that's the protrusion of the scapula. When patients do this, the stop sign with their extending their arms out. Hyperlordosis, we see that. Foot drop in more advanced conditions, muscular pain or myalgia and fatigue. Next slide, please. Yeah, so this is the classic, like now we can see the scapular winging in this first picture, like, pretty prominently how the scapula protrudes. So yes, one, they can make a stop sign, or, like you can make them have a push a little like gently on the wall by keeping both their arms on the wall and then push slightly, and then we can see this protrusion of the scapula. Now you can see in this top right image, around the scapula, there are a lot of the muscles, like we have the levator scapulae, rhomboids, we have trapezius, teres, like, so these are all serratus anterior. These are all, muscles which kind of stabilizes the scapula. And when there is weakness in these muscles, it can result in scapular winging. And also in the bottom left slide, you can see the atrophy or the shrinkage of these arm muscles, where the arm is much smaller than the forearm muscles. Basically tells us, that the arm muscles are very much weak. And you can see in the bottom right image, the patient is unable to lift the arm above the level of the shoulder, again indicating the weakness of the muscles of the shoulder girdle. Next slide, please. Now, facioscapulohumeral dystrophy can progress to involve the distal leg muscles, more so the anterior compartment, tibialis anterior. So that's the muscle, like which is affected in FSHD. And you can see here on the picture on the right, like how there is, this is the, like there's asymmetry, involvement of the right leg more than the left, and then how the bulk, the round fashion, like is lost, the curvature is lost on the outside, on the lateral aspect of the leg, and there is thinning and atrophy of the muscles of the right leg. Next slide, please.
Okay, so this was the second case of the gentleman who had the respiratory failure after morphine, 20 years of muscle weakness and pain and disability, and rhabdomyolysis after lightning strike with no family history. So this was a case that went to muscle biopsy, and it only showed a neurogenic fiber type grouping as if it was a motor neuron disease or a neuropathy. We also looked at evidence of metabolic disorder. We looked at stains for glycogen and lipids, and they were normal. There was no inflammation. And so his muscle biopsy was disappointingly unimpressive, okay? But I want you to pay attention to the patient's habitus. When we took his clothes off, and you'll keep hearing this, take their clothes off, you'll see many of these signs. You see this concavity, pectus excavatum, a very flat, underdeveloped chest, a very protuberant belly. So not specific for just his. We saw it with FSHD. We saw it with that case we presented to you in those images, abdominal muscle weakness, sort of curvature of his spine. And you can see a subtle pitching of his hips forward. You can't see locking of the knees, but his legs are far apart. But there is some similarity to his stance to the earlier videos of the gentleman who sort of had to stabilize themselves with their hips pitched forward. And so I was very impressed. And he had the beaver sign, where when he lifted his head or bent over, actually, his umbilicus went up when it should have been fixed. So even though the muscle biopsy didn't help me, because of the history and the exam, it was a red flag. And that goes back to your diagnostic approach. That's why the muscle biopsy, we don't lead with it, because it can be unyielding. Next slide. So suspecting muscle disorder, we at least started to get an EKG. He had some irregular heart rhythm and mildly enlarged ventricular size. His EMG showed, again, more of a neurogenic, denervating neuropathic or motor neuron process, but nothing to suggest a myopathy. And so we sent him back because for the myopathy I was suspecting, I said, we need to look at more muscles just besides the arms and the legs. And it's very important when you're referring your patient and you suspect a neuromuscular disease that you refer them to a specialist who has access or who is experienced with electromyography and nerve conduction studies, because they'll need to know how to test that patient. And so for many muscle diseases, you will get a greater yield of abnormality if you go where there's a greater amount of muscle, focusing on the pelvic girdle, focusing on the shoulder girdle muscles versus just the distal limbs, but also the muscles of the back may yield a lot more. And so when we did that, he had hyperactive muscle, fibrillations, positive sharp waves. These are signs of muscle irritation and myopathic units. And because of this, I chose to test him for a metabolic glycogen storage disease myopathy, and he tested positive for Pompe's disease, which is due to an enzyme gene mutation, and so he cannot metabolize glycogen to yield energy for the muscle. And that diagnosis, I think we can go to the next slide. Maybe that's it. That diagnosis allowed him to receive enzyme therapy, which had been FDA approved in the past 3 years. And he is still disabled, but can actually do some chores around the house. So Pompe's disease is a glycogen storage disease type 2. It's due to a mutation of an enzyme important for breakdown of glycogen called acid maltase. It's autosomal recessive. So again, no family history. He was that result of 2 parents giving him their carrier gene mutations. It occurs in 1 to 100 to 600,000, very common in African Americans, 1 to 14,000. Again, it can occur at any age. There are congenital subtypes where children present with cardiomyopathy, very sick, but you can also get mild cases where they present in midlife. So the progression can change. They can also have heart and organ involvement, such as liver involvement. And the severity is related to the amount of enzyme activity they have. So those are the classifications. The worst is the infantile kind, floppy babies born, respiratory involvement, needing respiratory support, can be fatal within 2 years of birth if not treated. And then you have the childhood, and then you have our case, the adult onset, who had respiratory failure. That was the red flag, a slower progression, fatigue and cramps. And without treatment, I'm not sure where he'd be, but he's still doing well. Next slide. So classically, we see high creatinine kinase. His was 480, but you can see higher than that, especially in the more severe forms. His EMG showed muscle irritation. You can have extra activity, not just where it looks like it's inflamed, where the muscle spontaneously discharges at rest or even with movement. And you get a greater yield where they have more muscle. So the paraspinous muscles of the back, the shoulder, and the hip. And then on muscle biopsy, they can actually do stains for lipids and glucose. And so this is, let me see if we can, I think this is animated. This is a staining for some glycogen. Then this is an EM, and these round circular things are collections of glycogen in the muscle, around the muscle fibers and the organelles. This is not normal to have this collection because the patient is not metabolizing the glycogen, is not breaking it down. So it's storing, it's causing secondary inflammation and disease. And patients can be diagnosed with genetic testing, or even you can do quickly a dried blood spot looking for enzyme activity. And now patients can be treated and are doing much better, especially the children, if they're diagnosed and started on treatment as early as possible. Next slide. And okay. Here is a longitudinal view of the muscle. You see the striated muscle of skeletal muscle, the striations, this is normal. But then you see these blobs of lysosomal glycogen, which should be metabolized and used for energy, but they're collecting. Next slide. Okay, so in summary, neuromuscular disease, there are over 30 neuromuscular disorders, and I'd say categories. I mean, I think if you look at the different types of neuropathies, different types of muscular dystrophies, you're well into the hundreds, if close to not to thousands. But now we have an increasing number that have interventional treatments, which can actually change outcome, including familial ALS, including Pompe's disease, including some dystrophinopathies, Duchenne. And so even in the absence of therapies, it's important to diagnose early so that we can intervene with rehabilitation, mobility devices, corrective surgeries to improve quality of life, to screen for comorbidities of heart and lungs, to improve survival. And so in the primary care setting, it is a prime opportunity to spot these symptoms and signs, to do some preliminary testing of muscle and heart, muscle enzymes, to dig into the history and the exam before sending to the neurospecialist. You will facilitate a diagnosis that much faster. And so what's good is that although there are hundreds, close to thousands of different disorders across these categories, they do share similar clinical profiles. So the job is not for you to know all the different subtypes with all the acronyms and the letters. We're hopeful that you can take some of these observations of gait, of habitus, of clinical history, the soft signs, the family history, and just have an index of suspicion. And you, as our partners in care, can begin that early screening and documentation that helps facilitate the referral and the diagnosis. Next slide. So there's a wealth of resources. We just chose some select articles which were published in the past 5 to 7 years about how to evaluate myopathies, Duchenne, ALS, facioscapulohumeral, Pompe's, and the like. And then the consensus guidelines is very good for the assessment of training of neuromuscular disease in general, which we recommend.